Before I start this presentation, I would like to just to inform the audience that this is my first presentation since I joined this program, and I'm not also familiar with this Zoom presentation. Okay, so our cases are our case is a young lady of 46 years old, HIV, positive CD4 count of 84, poorly controlled diabetes, who presented to surgery with DKA and also had a left parotid mass. He had some few interesting history, some interesting background. He had TB, PTB in 2018, which he completed treatment. Also had twice TB meningitis, the first one in 2019, based on CSF high protein. And then he had high ADA with a polynuclear of 152. There was no evidence, there was no macrobiological evidence. And then he received insufficient treatment of 6 months. In 2020, he was also diagnosed with TB meningitis based on high CSF protein. So he had lymphocytosis and he had a CT that shows cerebral edema. There was no macrobiological evidence. His treatment is tenofovir, emtricitabine, and atazanavir boosted. As you can see, she presented with fever and with this evidence of fungal infection on the pubis, though there was no any staining to confirm that she was having a fungal infection, but clinically we can see that this was in keeping with a fungal infection. She had a CT scan, which shows, this is the CT scan, which shows she had a left parotid abscess, which was loculated in the deep and superficial spaces. On the laboratory findings, she had an aspirated done that showed that she had Candida albicans, the confirmed Candida albicans, which was sensitive to fluconazole. She had urine MCNS, which grew mixed growth of Candida. At this point, we were concerned about a possible disseminated fungus. She had a blood culture, unfortunately, which was rejected because it was an old bottle, blood culture bottle. She had a parotid gland biopsy, which confirmed she had acute or chronic adenitis, but there was no evidence of TB or malignancy. Just want to talk a little bit about the causes of parotid gland enlargements. There are quite a lot, so it could be inflammatory, non-inflammatory, HIV-related, which I'm going to talk, idiopathic and mimicry, which I'm not going to take to talk about this. The risk factors are quite a lot, with HIV, diabetes, and antibiotics being one of the most common risk factors. However, there are many, as you can see on our screen. I'm not going to talk much about this anatomy, which is quite obvious, of the parotid gland. Concerning the non-inflammatory causes of parotid swelling, we have obstructive and non-obstructive, which I'm not going to take much time on this slide. Inflammatory cause of parotid glands, we have acute and chronic, but I'm going to take a bit much time on acute causes, which could be unilateral or bilateral. Bilateral cause, unilateral cause could be bacterial infection. TB lymphadenopathy also can present as a unilateral swelling of the parotid glands, and fungal infection, which is our case that we want to discuss on this topic. Bilateral presentation could be viral infections, in usually in HIV related, which, I mean, in HIV related, in HIV infected patients, we can present with DILS or BLEB, diffuse infiltrative lymphocyte syndrome. There are also other causes of bilateral inflammatory of, I mean, bilateral parotid gland swelling, which could be contrast-induced or bulimia, which we're not going to talk on this presentation. This is a classification, a criteria classification of DILS. For you to talk about this, you need the patient need to be HIV positive. They need to have bilateral salivary gland enlargements and dryness of the mouth for more than 6 months. They need to have a confirmed histological findings in keeping with lymphocytic infiltration, and all lacrimal glands infiltration, and with absence of granulomatosis or malignancy. As you can see, histological finding on this slide on the right below this side. Oh, sorry, lost this. There are also external causes of or external manifestation of DILS, which could be peripheral neuropathy, T cells, lymphocytosis, lymphoid interstitial hepatitis, lymphoid interstitial nephritis, dysmotility syndrome, and polymyositis and mastitis. As you can see on this CT scan, which show an LIP, on this CT scan. There are also cases of drug-related parotid gland enlargements, such as protease inhibitors. There's some case report of a 58 years old male with bilateral parotid gland enlargements for 4 months, and he has been on protease inhibitors. And then after stopping the medication, the enlargement stopped. Another young male of 38, avid drug user, who was on 10 months on protease inhibitors regimens, presented with parotid gland enlargements with buffalo hump, which was stabilized on continuation of protease inhibitors. This slide showing how ARVs contribute to the reduction of the DILS syndrome. I think the slide is self-explanatory. So I would like to say the treatment of or the improvement of DILS is HIV treatment. So since the introduction of HIV treatment in 1997, the cases of DILS have been declining. There are a lot of causes of fungal infection which are associated with parotid gland swelling, but the most common one is Candida albicans, which represents 80% of the cases. Concerning the treatments, there are actually four principles. So you need to identify the type of fungal infection. You make a correct diagnosis And then you need to find what would be the predisposition factors, which would be HIV, diabetes, as I gave them in the previous slides, or immunosuppressants. You need to address those problems. And then after identifying the the fungus, addressing the problems, you need to give the proper antifungal. So this is some case studies, some case reports. This case report was done in France of an elderly man who presented to emergency department with a left parotid gland enlargement. He was also having features in keeping with inflammation. He had high CRP infection, high CRP fever, and tenderness. He was so he had an ultrasound that showed a pseudocyst, and then he had an aspiration of the swelling by FNA, and then the aspirates, which was sent to the lab and shown growth of Candida gravata. So this happened in France. And the patient was started on antifungal, appropriate antifungals, and so was very good resolution of the symptoms. Another similar case was reported in Amsterdam, that's in Netherlands. A elderly lady. We come back to this phase one, this slide, sorry. So this patient didn't have any risk factors such as diabetes or HIV. These were not reported. The only risk factors was he was on a danger for more than five months, for quite a long time. So that was the only risk factors that was found for this patient. And this case report in Netherlands of an elderly man who was also who presented to ENT with similar presentation, left parotid swelling. He didn't have any risk factors such as HIV or on immunosuppressant or diabetes. He was on a prolonged course of antibiotics for more than 5 months for a suspected infected endograft. On presentation, he presented with a left parotid swelling with features in keeping with the infection. So he has also elevated inflammatory marker. CRP was high. He had fever, a temperature of 38. He also he had an ultrasound that showed a pseudocyst, and then had an aspiration, FNA, that healed. Aspirates healed Candida tropicalis. He was also put on antifungals, and they responded very good to treatment. So this is the end of the presentation.
Thanks very much, Paul. If you can stop sharing your screen. So yeah, I mean, parotid involvement in HIV in the early days, we saw a huge amount of DILs. You could spot it pretty quickly, and they had these sort of multiple cysts in the parotids and often other symptoms in relation. We don't see that very often anymore. I think what's interesting about this this case is that there's an amazing paucity of literature and case reports of fungal parotitis, particularly in HIV. And with the amount of Candida, oral Candida that one has, I guess it's a testament to good drainage of usually of parotid glands. Now, the CT didn't show any blockage, and of course, Candida infection can complicate non-inflammatory causes like duct stones and malignancies, etc. But the fact that this isn't very well described is quite interesting. Whether it was the pathogenesis was via directly from the mouth, or whether there was hematogenic spread. She certainly had vulval candida and around skin around the mons pubis. There was a question about disseminated rash, but I don't know what the dermatologist finally said about that, but it looked more like a pustular psoriasis. But I don't know if others, Eunice, if he's still with us, and Graham, others, whether you've seen much Candida parotitis, parotid abscesses. It's the first one I've seen. Over to you. A lack of response suggests that nobody's seen it.
I haven't seen any, but I was just wondering, how was the specimen obtained for culture? Because Candida is a colonizer in the mouth, so it can be difficult to differentiate.
Yeah, no, this was a direct aspirate from the parotid abscess, directly through skin.
Ah, okay.
It wasn't it wasn't from the buccal area.
Yeah, Mike, I've not seen it, and I guess what was going through my mind as well was the same as Eunice, as to whether, whether some of these could be a bacterial infection with Candida superinfection. But this patient's response was to antifungals alone, or?
Yeah, he had antibiotics initially, which didn't improve matters. I mean, you could easily argue that that's because there wasn't proper source control. Mm-hmm. But I'm guessing that at the time the aspirate was taken, he may have already had an antibiotic. So yes, it's possible. But he had fairly heavy growth of Candida on the aspirate. He did have evidence of Candida elsewhere. So yeah, it's interesting. But I come back to the fact that it's interesting that we don't see more Candida parotid abscesses or abscesses around the mouth and esophagus, because we see so much Candida, but I guess it just doesn't translocate across very easily. Sipo, your hand is up.
Yeah, no, I was just going to say that, I mean, even in HIV, when we see sort of candidal infections, it's usually localized. I mean, the one you could say we see more often in terms of quite aggressive diseases, Candida esophagitis, right? But in this particular lady, this is quite an aggressive candidal infection, sort of invasive. It's deep and soft tissue infection, which is not something you usually see in HIV. And that's why, I mean, you kind of see these kind of aggressive, if I use the term, fungal infections in diabetics. And I think this particular lady, in fact, had an HbA1c of about 16. So showing that she's really, really poorly controlled and really, really a weakened immune system, reduced phagocytic function. And this is quite an aggressive fungal infection. I think that shouldn't be missed.
No, I think that's a very good point. Sean, as our resident fungal expert, anything to add?
Well, I think this is TB. I mean, I made this point in the ward round. I mean, just to kind of explain this to people. I mean, there was so much pus coming out of her parotid. I mean, that's put a bag over it. I mean, just a really, I mean, you could appreciate it from the CT scan, but a very large abscess. And, I also, like Eunice, had concerns that this could have been a contaminated culture from the skin. And I think really a big effort needs to be made to exclude tuberculosis as a cause of unilateral, and I assume chronic parotitis. I'm not sure exactly when her symptoms started, and that might be interesting.
Yeah, I mean, maybe Paul can help us with that, but my memory of the case didn't suggest that she had long-term symptoms or that she had constitutional symptoms with it apart from fever. But I may be wrong. I may be not remembering it properly. Nectarios, or or Paul, Nectarios.
Hi, Prof. So just to answer a few questions, the derms saw her and they were considering it to be Candida folliculitis. Ophthalmology also saw the patient because we were considering disseminated disease to the eye, and on a limited examination, they felt that there was no fungus balls in the eyes. And from a TB point of view, the patient's already been on TB treatment since December for this query, tuberculous meningitis. And the one confounder is that I can't find records on the pharmacy, but the patient's on atazanavir, ritonavir, and I'm a little bit concerned that she was getting actually refiner at the day clinic. So I'm not sure how that. I think that might affect our treatment options. But the gene expert on the pus that was taken now is negative, and the TB culture is currently pending.
Adherence to ART seems to be intermittent, and TB iris has to be a consideration.
Sure.
Yeah.
But at the present moment, in fast TB, the computer says no. But we'll have to see what comes up. I mean, I think these are all very valid issues. I think the fact that it was an aspirate from the parotid, yes, of course, you can get potentially get skin contamination. Doesn't seem to have had much of the skin rash. The rash that there was, which I thought was pustular psoriasis, which I'm happy to be proven wrong about, wasn't overlying the parotid. But of course, that's possible. But a heavy growth of Candida from the abscess is of concern. And then it may be polymicrobial. She could have TB and Candida in the same thing, or bacteria and Candida. Paul, you have your hand up.
Yes, Prof. My concern of not a concern. I thought this patient has a Candida. If you look at the temperature chart, so she was initially started on antibiotic. She was, first of all, she is on a continuation phase of TB meningitis, which is going to finish maybe in a couple of months. When she presented to them, to surgery, she was put on antibiotics for quite sometimes, like maybe 7 days. She also had a drain, like a source control prior to antifungals. You look at that temperature chart when she was started on antifungals, so immediately, like 2 days after, the temperature dropped immediately. So until now, so it sounds like a fungal infection with a good resolution after antifungals were started.
Thanks, Paul. I mean, it's always difficult because there's a few confounders there. The antibiotics initially didn't work, which may have been because although she had a drain in, as Sean said, she had to have a bag over her parotid, drain because there was so much pus coming out. It's very deep infection. So you can't rule out the fact that the continued temperature actually just was relating to pus, and that the timing just seemed to coincide with the start of the antifungal. So it's really difficult. And then, as Tari had mentioned and others had mentioned, the question about antiretroviral adherence, the possibilities of an iris phenomenon. And what's interesting as well, that initial TBM diagnosis, although there's a high protein, very high polymorphs, there weren't lymphocytes. Again, whether that could have been TBM iris or whatever. So there's quite a lot of unknowns in this case. Maybe the fact that Candida parotitis is so uncommon and there's so many confounders here means that it isn't. Or in fact, as Sipo has said, because of the severe nature of her diabetes and the poor control has played into it as well. But we'll keep an eye on this and continue investigation and see how she does. And try and feed back. But I'd really like to